work that.
Sorry, ladies, I forgot to push that button. Now it's going.
That's all right. Perfect timing, Kate. Today I'm going to talk about work that I've been doing since late 2018. And what happened was the now director of Queensland Health asked at the time for around a project. He wanted a methodology that was actually proven, but also that would reach out into grassroots community. So yes, there are consumers through health services, through Queensland Health, who have an amazing voice and very informed. So as well as hearing from them, he also really wanted to hear people out in the wider community. So he asked us to come up with a methodology that we could actually use, and the one that I've always wanted to use because it is about consumers. And that is the kitchen table discussion methodology. And you can use this in so many varied ways. And you do hear from those who do not normally participate in more formal consultation. It's a really inclusive process because we have men as hosts and they love it. We have women as hosts. We reach all age groups, all cultures. It's so inclusive and it just allows you to hear from those diverse groups, including the hard to reach and the disadvantaged. But the biggest point about this is, yes, consumers are the ones who actually lead the consultation. It's not us in the room. It's not health staff. It's not professional consultants. It's actually you as the consumer who is the one who is there hosting and organising a consultation and actually sharing with people from your community in a safe, friendly and supportive environment. All the photos throughout this presentation are actually real live kitchen table discussions. So just so that you can see the faces and the happiness as people come together in many different places around a table, sharing a cuppa and some refreshments. And these are some of the faces, and this shows you this process for consumers works no matter how old you are, no matter where you are, no matter what culture you are. It is so inclusive from that perspective. So the aim of it is, it's for community members to have the opportunity to have their say about health issues and services that impact on them. So what comes back from the kitchen tables discussions is not just dot points and minutes, it's not people answering a survey, but they provide really comprehensive feedback. And the host is the one, and maybe they have a scribe with them who is collecting all of this information and sending it back to us. But what you're also getting, and what health organisations, you will hear from Natalie later, and from Joan, is that you're hearing stories, you're hearing real life situations, you're hearing pain, you're hearing joy, you're hearing how people are really feeling. And you're also hearing their knowledge, whether they know about a particular health service, whether they don't know about it. So with the hosts and the participants, they find it incredibly valuable because they have an opportunity to speak openly in a safe and friendly environment. And they also appreciate the opportunity to input into projects that impact on families and the broader community. So why else would you use them? Because it ensures health services are doing with you as consumers and not to consumers. It enables new services, models of care and facilities to meet a diverse range of consumer needs and wishes. It leads to better person-centred care and more appropriate and user-friendly services. And the most amazing thing is it also supports consumer health literacy, because while people are sitting in those groups, Someone may have more knowledge than another person around this health service or what is being provided. And so they're informing other people at the same time. And so people will say, oh my God, I didn't know that. And now I have more information about that. So they're doing it together and they're sharing and learning together. So why do people think about this process and why do they like it? Because they feel that their voice is being heard and their views are valued, and their words that come back to us all the time. I feel like I've been heard. I feel like they really wanted to hear from us. It enables culturally safe consultation. It relieves consultation overload on consumers. And what I mean about that, often we hear that people and consultants have gone into different communities, and especially imagine this in a rural and remote area, where you have people coming in from maybe federal government and state government and from the local health service and the local council, and they're all coming in and they're all wanting to consult with you and they all want to ask questions. But you may never ever hear what actually came out of that, and you may never see change. So you're actually doing the consultation this time, not those outsiders. But it also allows for really impartial discussion and also for feedback, because you're creating as a host a really safe environment where everyone's voice is important and what everyone says is important. And everyone needs to be respected in that process. And no one is right and no one is wrong. It just enables an open process. And participants and hosts enjoy the process, and they consistently say to us that they want more of this type of consultation. And I wanted to share here just a few quotes that we've received, and we received so many quotes back. The first one on the left-hand side is where this was a really interesting one, where when we work with Aboriginal and Torres Strait Islander people, First Nations people, they will call this a yarning circle. So they don't say kitchen table discussions, they refer to it as a yarning circle. And this was a very challenging one, which was specifically for First Nations women, and it was around unplanned pregnancy. And yet in this circle, what happened was a young woman joined them who actually was pregnant and felt that she had no one helping her and supporting her. So these women all came around her and actually agreed to support her in any way they could throughout her pregnancy. So what an incredible way for this to happen, to go from one point of discussion into supporting someone else. Another group said, what an incredible time we had. Seven women from all walks of life bonded on a very deep level as we all shared our stories and answered the questions. For another said, I've also heard through the small town feedback loop that the ladies who met for the kitchen table discussion about end of life are still talking about how meaningful that experience was for them. What a wonderful experience it was for all of us. And for another, I wanted to let you know that the attendees thought that this was the best and most enjoyable session we have had. We had tears and enjoyable conversation, but all present thought it was very good. And together we all said, let this lead to change. And finally, so many tears, laughs and hugs were the order of the afternoon as we discussed the questions. And I did a high tea for them, which they loved. I had soft music, candles burning everywhere to set a warm, relaxed atmosphere, and a box of tissues. Thank you again for this amazing privilege, and I hope you will consider me next time. These are comments that we are hearing back all the time, consistently all the time. And I've heard from men where for the first time, you know, as a group, in a man's group, they all hug each other at the end and they all have tears. And for some, when it's a really challenging kitchen table, it's cathartic for them, because often people are never heard, they never get to share their stories. But in this process, coming together as community in a safe environment, you can do that. And that's one of the things they truly love about this process. So what's great about them also is that it's, again, consumers lead the consultation, not consultants or staff. You're hearing directly from the community, and enables access to a broad and diverse cross-section of community. So what makes them successful? Obviously, consumers make them successful. And our hosts have to have good community networks and connections. And they must commit to be able to undertake their sessions within the set timeline. And this is a tight one. My projects run for 6 weeks, from the start of the project when I recruit my consumer hosts to the time that I analyse the feedback and present the report back to the host organisation. I've got 6 weeks. And the hosts, after we train them and brief them, basically they have 2 weeks to set up their sessions, to undertake their sessions and return their feedback back to me. And they used to say to me when I first started doing this, and 2 weeks is too tight, we can't do this. But the interesting thing is I gave them 3 weeks and they went, that's a problem because we lose our focus. So we actually need to keep it within 2 weeks. So we've always stayed 2 weeks. It's about hosts are not there to drive their own agenda. They've got to be impartial. And the other thing is that the people who are hosts can be anyone. You can have any literacy level, you can be any age. You do not have to be someone who is experienced in facilitating or hosting. You can be anyone. And this process is really good for small group discussions. So we used to have up to 10 people. Each host would have up to 10 people. But of course, then COVID came in and had to very, very quickly look at how do we actually continue to do this work through COVID and with lockdowns. And so we took these sessions online. So through last year, they never stopped. We kept consulting. We kept bringing hosts in and doing incredible work and getting incredible outcomes by going online and using Zoom. And we reduced the numbers of participants down to 6, 5 or 6, so the host could manage it. The other thing that makes them successful is that we remunerate our hosts, and we remunerate them at our day meeting rate, unless they're doing it online because it's less work for them, at our half-day meeting rate. We reimburse them for catering. So we give them a catering budget, but we also give all of our participants a $60 gift voucher for their time. And we have had some who have said, look, I don't want that, I don't need that. But, you know, it's about acknowledging the fact that people are giving their time, and we value that. So hosting a kitchen table, really to be able to do this, you have to be able to reach out into your community networks and gather together an agreed number of community members, whether that's 6 or 10. You're the one who creates, as the host, the safe and friendly environment in which the session is held, and you're also responsible for holding that session within that set time frame, as I said, and getting the outcomes back to me. It's an enabled process. That's the thing I wanted to say. And where do you hold them? Well, you know, in community, at a home, in a backyard, a cafe, library, or an outside area such as a park or barbecue area. Where you hold them is up to you as the host. It's somewhere your participants will feel safe. It meets their accessibility needs, where you have privacy to share information, because some of these sessions can be incredibly sensitive. And if your participants are people who are unwell, again, that's when you can use that online process instead of bringing them together at a venue. And sometimes our hosts have actually mixed up and had their session somewhere, but they've been able to bring in those who are not able to travel or are incredibly unwell via Zoom to participate in that session. We allow the host to choose that. They're the ones who decide what's going to happen in their sessions. So as I said, we support our hosts all the way through this process. So we give them an online training and we give them a briefing session around the project so that they feel really comfortable that they know enough. They're not experts. We don't want them to be experts, but they know enough to be able to facilitate and run their session. And each host has the same set of questions as the other hosts. So they're all working from the same questions. And we give them a full toolkit, which we email and we mail out to them with all the printed out copies of everything they will need. We make it as easy as possible. We give them a really comprehensive guide so that they know how to run their session, what to look for, how to support people who might get upset. We give them a list of support services that they can give out to people. We give them ongoing support and mentoring through that process. And then once I've got it back, all that information back, and it's analysed and the report is done, then what we do is we actually have another session where it can be debriefing for them, but it also closes that feedback loop session. You know, it's that we heard you, we listened, this is what came out of this. And we ask them then to feed that information back to their participants so that they also know that they were actually heard. So when do we use them? You know, this is an interesting one because at times I thought, oh gosh, this is going to be a very difficult session and I'm not sure it's really going to work. It's amazing how it's worked. Since late 2018, I've worked on 31 projects and I'm just starting another one this week. So more than 200 kitchen table discussions. We've done an amazing array of projects, but just some of the bigger ones that we've done is what has just come live in Queensland, the first in Australia, is Inform My Care website, where consumers have been involved, and this is our first project we started in late 2018. 3 rounds of kitchen table discussions, 12 focus groups, consumers involved in health literacy reviews and consumer representatives on the project. And this is about consumers can now go in on this website and actually see information around safety and quality within hospitals, public hospitals and public hospitals, private hospitals, and some aged care facilities. So the consumers were so much a part of creating what that website looks like. Also, they were very much involved in the development of Queensland's Digital Health Consumer Charter, the first such charter in Australia. We consulted with some 400 people in the state around talking about ageing, end-of-life care and dying in 2019. We've done a national project for CHF around the future state of primary health care at the start of COVID. Hospital in the home services, impact of COVID on rehabilitation services in Queensland, and also a Queensland Health website transformation project. And now the one that we want to share with you today that involve kitchen table discussions and focus groups with the hosts and the participants to follow. And that was around high benefit care at the end of life. And for that, I would like to hand over to Natalie.
Thanks so much, Anne. And thanks so much everyone for joining us. It's really lovely to connect with so many of you. I've already had a bit of an introduction, but like was already said, my name's Natalie and I am a physio based up in North Queensland, and I'm just presenting today on behalf of my colleagues who joined me on the project. And give you a bit of a rundown of the project, just to show how the consumer engagement, particularly the kitchen table discussion elements, really tied into our project and really shaped it and made it the way that it was. So just moving on to the next slide, just like to acknowledge the project team, like I said, that I worked with on the project, including a user experience designer. Her name was Jessica Cheers, and I'm not sure if anyone in the audience was part of our kitchen table discussions or our focus groups. If you are, welcome. It's lovely to have you with us. But Jessica was very instrumental in the later part of our project with regards to our focus groups. So just a little bit of background I thought we'd start with, just to sort of take you on a bit of a trip with me in terms of why our project was the way that it was and how it came about. But basically, we acknowledge that sometimes people report that either the communication or the treatment or the care that either themselves or their loved ones received in the context of end of life treatment or care was maybe different, or perhaps may not have been completely aligned with either their wishes and values or the wishes and values of their loved one. And so just on to the next slide, the aim of the High Benefit Care at End of Life project was to guide healthcare professionals to deliver high benefit, patient-centred care at end of life. So really looking at what high benefit care looks like for people who've been diagnosed with a life-limiting condition, and that includes advanced disease and frailty, so becoming older. And our project was made up of a working group, which was almost entirely healthcare professionals and consumers. So people who've been patients or carers or used the healthcare system themselves in some way. And the whole point really was to come up with a solution that helps us to deliver maybe care differently. So then on to the next slide. So to make sure that we did come up with a solution that was useful and valuable to the people who use it, which I guess is all of us at some point in our lives, we needed to understand what high benefit care really meant to people. And we needed to better understand how people wanted to be empowered, or how they wanted to be included in decision making about the treatment and care that is right for them. And really, this was going to shape particularly the later part of our project. So on to the next slide. Oh, sorry, I think you'd already moved on. Oh, yep, that's the one. Perfect. Thanks, Anne. So we collaborated with Anne from Health Consumers Queensland, who you've heard lots from already this morning, to conduct 2 phases of consumer engagement. So phase 1 included meeting with consumers to give them some information around the project and sort of outline what we hoped to learn from them as hosts, and then also their participants, and just really provided some background there. And then the kitchen table discussions were held across Queensland, and as Anne said, included lots of different people from all over the state. So we had around 130 people from all different genders and cultural backgrounds, different locations, and all had varying experiences with healthcare settings. And a report was put together by HCQ around some of the main points, but we also had access to some of the raw data in terms of the conversation, so that we could really explore what people's experiences had been in the context of end-of-life care and treatment. And then phase 2 was more around user testing of the solution that we came up with as a project team, and that we developed as part of the project. So then onto the next slide. I've just popped a few of the key findings from the kitchen table discussions here. And I guess, as you can see, it's incredibly valuable information and was so very generously provided by our hosts and participants. So much so that our clinical lead on the project, Dr. Robin Brogan, said that it was one of the best reports that she'd read in her 30 years as a specialist palliative care consultant. And so you can see this information here. People really want to know if they have potentially a condition diagnosed that might limit their life. And they really gave us some wonderful information in terms of how they'd like to receive that information, the type of language that is used, a real emphasis on having time to ask questions and have them answered honestly, and having time for those conversations, and a really strong preference for families and caregivers to be involved in decision making. And so this information was able to be put together from the information that we'd already received from our working group, really to make sure that we landed on the right solution. So I think there might be one more slide to that bit, but I think it's after Joan's section. So we can maybe even finish it there, Anne, and I can just talk to the next bit in a bit.
Great. Thanks, Natalie. Yes, so introducing Joan, who was one of our hosts, and this was your first time, Joan, as a host.
Yeah, hi everyone. My name is Joan Carlini. I've been a consumer. I think it is important. I'll just give you a little bit of background about who I am. I've been a consumer, as Kate had mentioned, with the Gold Coast Health Service for about 4 or 5 years. So I would say I'm a fairly experienced consumer. And with that in mind, I think it is always really important to, I guess, making sure that you do get diversity in your group and ensuring that you really are amplifying the voices of others. So that's always a really important factor for me. So firstly, when I had seen that these kitchen tables were happening, so I do some different things with Health Consumers Queensland. I'm definitely on their newsletter, so I'm always aware of what opportunities there are. So when the end of life one came around, I did and ah for quite a while. Like end of life is something that really interests me. I've worked on a couple of different projects in end of life. And then finally, the motivation for me to, fill in the application form and to submit it was just having a talk with, sorry, I think the garbage truck is about to come round. Just having a talk to some friends, one of my friends, her mum's in an aged care facility, and her experience at that point in time. And it was a really emotional conversation. And I was like, actually, I really need to do this. It's a real issue of concern, and I have an opportunity as a health consumer advocate to give a voice to people who are going through this at the moment. So that's how I see my role. I see my role as someone who can give others a voice, especially, through my experience as a health consumer. So I'll just keep going. Around the kitchen table discussion. So that was the motivation. I think you do need to sort of assess your motivation. Why do you want to do it? And then the practical stuff was, planning. And in the planning, you need to identify people who will be part of your kitchen table. So with end of life discussion, I reached out to quite a few of my network, and diversity was really important. So I wanted a mix of, this was important to me. Maybe other people and other people's kitchen tables weren't as diverse, but for me, it was something that I really wanted to achieve. So I had diversity, I wrote them down: gender, age, culture, religion, experiences, conditions, health, values, family structure. And I have lots of, I guess, networks, so I didn't really find it too difficult to reach out. But certainly trying to navigate, when people were available in different times, that was really tough, actually. And in actual fact, some people who really wanted to participate but were not able to be available on the time that I ended up selecting, they ended up filling in the profile that Anne had sent around. So, the list of questions that we were asking, they particularly asked for them. I supplied them, and then they forwarded them back to me, which I then collated their responses as well. And the next thing is around, action. So for me, I really did think carefully about a safe space. And so what come to mind for my particular group, and probably different for other people, was convenience, location, accessibility. They're the types of things that I thought about when I was organising the location that we would meet. I just wanted it to be sort of open. And also it was a sort of time around COVID when we were having face masks and not having face masks. So, I just was mindful about that as well. But also making people feel comfortable. So the money for the food and beverage, I thought was really excellent, because the participants, our friends, really did enjoy, they felt really respected. When they turned up, I was able to, get them a coffee, and we had some food there. So it did actually make it a really informal, talk. I'm just checking the time. Okay, still going. So yeah, I think that is really important. When people turn up, I, greeted them. I'm not sure how, did I give mug? I'm not sure, but you know what I mean? Like, to make people feel really welcome. And then the questioning, it was a very organised, we'd attended training, and so we were very organised in our method, which was great. We had our toolkit in front of us, and, as Anne mentioned, you were scribing or had a scriber there to assist with the note taking. But there wasn't a lot of questions. I can't remember how many, but the amount of information is quite overwhelming. Like, you know, for me, we did go around the group, so everyone would have an opportunity to talk. And then there was interaction after they had said their piece. So people might ask questions, but people were let to talk first. So there was a lot of information. And also, I also recorded the session. You don't have to, but for me, I really did want to ensure that I didn't miss anyone's expressions. And I wanted to take, I guess, the pressure off me to make sure that I got the context and stuff right. And after the kitchen table, I did some I had the actual quotes and then some synthesizing as well, and I sent it off to Anne. But I did want to, in what I'm talking about and the experience of the hosting role, but I did want to, I reached out to a few of the people that come to my kitchen table, and I asked them to provide some feedback on what their experience was. And I thought that was really important. So it's a bit of a closing the loop for me, because I find my role as a health consumer, really important. And I want to make sure that people that I interact with feel heard, feel respected, feel safe, and all of those things, because I just want to make sure that I'm not taking my role for granted, and that everyone does actually feel heard. So I've got another minute, so I'll just quickly read through some of the feedback from the people. So from a 50-ish woman who's culturally diverse, whose mother, grandmother, carer lives with chronic diseases, she said that she found the format, age, dynamic, and different perspectives a definite positive. The discussion covered from personal experience, education point of view, and a work perspective. And so that was really interesting that the people who attended noted how different, people's religions and lived experience were that contributed to the conversation. The next one was, although overall I thought the end of life discussion was positive, it was interesting to hear a range of different perspectives on the topic. I thought it was a great way for everyone to contribute equally, and people were able to put forward their own experience, which helped me better understand end of life. I wasn't overly exposed in my own experience. The only negative was that they would have liked more time to unpack the topic. So you can see that people really did value, the talking experience and the sharing. She found that it was incredibly healing to talk about such a sensitive topic with people who understand the difficult emotions associated with end of life care. That feedback was actually from a young woman in her 20s who's a student daughter and granddaughter. So you can see, that it's not just for elderly people or people at end of life to be talking about this. It's really important to include young people as well. And I'll just do one more. This feedback was from a man who's in his 70s who has gone through cancer treatment, which was experimental at the time. And he's also an experienced consumer as well. So he said that the discussion is that the format of the questions and general discussion was not skewed to achieve a preconceived outcome. So that's great. He didn't feel there's any bias, and he felt comfortable to discuss an issue we must all face with our concerns in the appropriateness of my opinions. So you can see that in actual fact, people did feel safe and they felt like they could be honest. Thank you so much. And I'm back later on the agenda.
Thanks, Joan. I'm just going to hand back to Natalie, because there was a second stage to this once, as Natalie said. So just to talk about focus groups and how we used some of the hosts and some of the participants in this process.
Thanks very much, Anne. So just before I go on to the focus groups, I just wanted to touch on, I mentioned earlier that we were coming up with a solution. in terms of the outcome of our project. And really, when we started the project, which was a little bit unique to us, we didn't have an idea of what that solution would be. The car was completely driven by our working group, made up of our clinicians and our consumers, but then also our collaboration with consumers as part of this process. So our kitchen table discussions really kicked things off for us, but then our focus groups really refined it. So with regards to our solution, I thought I'd just talk to you about that a little bit. So the solution that we landed on, that was, like I said, informed not by us as a project team or clinicians or anything like that, but by consumers and our clinical working group, was a decision aid. And you might not have heard much about decision aids before. I hadn't really heard much before I started working on this project. It's not something I use traditionally in physio land, but basically they're tools designed to support shared decision making when there's more than one option to choose. And they can be pretty handy in healthcare settings when perhaps there's some uncertainty around maybe a particular treatment or a particular direction, might have a number of options, and you might want to work through that in a particular way, or you might be a bit confused about what direction to take. And this is where they can come in handy. We designed our own decision aid as part of the project, like I said, very much based on the feedback that we received from people like Joan and everyone else within the consumer space. So you can see this slide that Anne's got up on the screen here. This is a bit of a mock-up, and people had asked, in the chat about Jessica. So Jessica Cheers is user experience designer, and she came on board when we were designing our solution, because we're all clinicians by background, and we're a bit hopeless when it comes to design. So we were thrilled that she came to help us. But this was our very early mock-up, and we were toying around with the ideas of whether it would be best in print or whether it'd be best in digital. And this is sort of before we'd engaged with consumers around the design. We can go on to the next slide there too. You can see there it's sort of just in one colour there. We thought it might be in a book format. This is basically just where it started. But then we got tons of feedback from our focus groups, and we were so thrilled because there's absolutely no way we would have landed on the design that we did at the end without the feedback. And some of that feedback was very interesting and things I never would have considered. So there were things from the title, so people really wanted to connect with it. The style of document, they wanted it to be not overwhelming and something that they could really identify with and felt safe to them. We got feedback around the paper weight and quality, around and very interesting, something I never would have thought of in terms of the weight or the quality of the paper denoting its importance, which was just incredibly helpful feedback. Information around sort of the colour scheme, and that greens represented healing, and they wanted to see that sort of tonal colour scheme throughout. They wanted it to be a document that sort of could be developed over time, and there was maybe a little bit of a preference for it to be something you could hold in your hand, particularly when it comes to being able to access various online platforms and whatnot, which might be tricky for some of our consumers or people using our healthcare system. People really like the idea of a folder so that they could throw a few extra pages in if they wanted to take notes, or they received information from people, and really just wanted that closeness and that connection of being able to hold on to it. They wanted some illustrations, so we had some blank sort of bubbles there, which we hoped sort of looked a bit like a path, but people didn't really see the path, so that was also very useful to receive. And in the early stages, to be honest, people really did say that it wasn't a document that they could connect with. They couldn't see themselves using it, and it felt a bit tick and flick. And so receiving that information, obviously, early on was incredibly helpful because it shaped the direction of it moving forward. So Then by about the third focus group, we were really able to incorporate all the feedback into a more sort of informed document, thankfully, that people felt that they really connected with and was useful, and they were excited to sort of be involved in. So this now is sort of what we came up with based on all of that engagement. So we had 3 or 4 focus groups in total. And this was the front cover that we landed on. And we can move on to the next slide there. We'll just have a bit of a look. So these were the 4 sections, and we'll play a video if it works at the end around what our vision is in terms of its usability within a healthcare setting and how it might benefit people sort of in this space, have honest conversations in the future. But we've got the steps there in terms of truth telling, of exploring values and preferences, to then assist with the decision-making process on step 3 there. And then finally, next steps, or having a look to see whether any more information is needed before a decision is made. So it's a decision aid, it's to support decisions, and very much informed by our consumers. We can go on to the next slide there. I think there's a few other pages there. So these would be 4 pages that would slot into a folder, and then they're double-sided, and so the contents on the reverse side of the page. And then just moving on to the next slide there. So we've got a folder format there, which was completely designed with the consumer's feedback in mind. And then I think there might be one more slide there. And this is a book format, and we're thinking maybe we need to more make a book format for the clinicians who might lose the papers everywhere. So we're toying with a few other designs, and we really hope that we can implement it moving forward. I think that might be the end of my little bit there, Anne. Oh yes, so this was a slide I think I've already spoken to, but basically this just talks about what the decision aid is there in terms of it's designed to support shared decision making when there's a life-limiting diagnosis that's been had. And we certainly hope that what we've come up with as an early prototype informed by consumers might be something that we can take forward into the future. Thank you, Anne.
Thanks, Natalie. And Joan was as one of our consumer hosts. So we had 5 hosts who participated in the first 2 focus groups, and then we changed track, and then the third focus group we brought in 5 participants from the kitchen tables, and then we brought them all together in the 4th session. So Joan, you were one of those hosts, so over to you.
Yeah, thank you. And being part of the kitchen table discussion was excellent. And like I said, I was just really grateful that they chose me. I was like, oh, thank goodness they chose me, because I was really grateful to be the host. I really was. It was such a great experience. You know, I was honoured. But to then go on and be part of the focus group, that just went up a notch. You know, I keep saying this to Natalie. You know, to see what they did with the conversations from the kitchen table discussions have just been amazing. We turned up at the first focus group, and to see how they had synthesized the data and produced the original booklet was just insane. So yeah, to be part of the whole journey from start to almost finish, you know, we're hoping that the journey's not finished, that's all, has been an absolute fantastic experience. And during the different focus groups, as Natalie had said, you know, the feedback on the first one was, you know, on the first version was actually, you know, it's too long, the language is too difficult, it's in the wrong order, it doesn't make any sense, to just name a few. But still, it was still amazing to see how they had taken the 16, I think, kitchen tables and turned it into something. And then when we met 2 weeks later, they had taken on board all of that feedback, and what they presented was absolutely amazing. And you know, and so I had sort of said to Natalie, you know, I sort of felt like the criticism was quite harsh. But but it was real, it was authentic. That's what people said. That's how they really felt. And to see what the team had done, and Jessica, and the latest version that Natalie had just been through, it actually is what people want. It's exactly what people talked about. It's something that you do want to take with you. It's something that you do want to fill out, something you do want to talk about, not something that you go, actually, this makes no sense to me, like I'll just file it. So to be part of the kitchen tables and then come along with the journey with the focus groups has just been a wonderful experience, and I hope that Natalie and the team are able to continue.
Thanks, Joan. So just before we go to the video, and Kate's going to play the video for us, why we wanted to share this today is that there's such an opportunity for you with your own health service or organisation that you're a consumer with, to actually take this information back and make suggestions that maybe kitchen tables are the way for you to go, and maybe it's about not just having one process sometimes, but maybe it's also there's a follow-up process, because we see amazing outcomes, and this project has had a very amazing outcomes in a very short turnaround time. And the consumers love the fact that this is what they are seeing. So it's just to say there are other ways to engage and consult with community and to reach out. And these are just the ways that we work here at the Health Consumers Queensland. And we work with Queensland Health and other organisations to do this. So Kate, the video?
Yep, could you stop sharing and then I can?
Yes.
Thank you. Managed to lose everybody. Can you see that?
We're not seeing it, Kate.
Oh, okay. I'm seeing it. Looks lovely. Let's see if I can hit that again.
It's right now.
I'll start. Sorry about that. I'm going to go back to the beginning.
No worries.
Sorry.
We're just not getting any audio there.
With respect, that's could be a good thing. The audio is a bit iffy. Look, I'm really sorry. I think I might just attach it to the presentation, because the sound is fine for me.
That's okay. That's all right. Kate, I think playing it online, it has been a little bit difficult before, but yeah, if you do send it out later, everyone can sort of watch it with their good audio at home. But basically it's a mock-up of a video in terms of what our outcome was, and I guess what our vision was throughout the project, and what we've landed on in terms of our decision aid. And it just goes into how it might be used in clinical settings. And I can see a few questions having come in the chat there, and no, it's not been implemented yet. And certainly that's the next part of the project that we're wanting to look at. The deliverable from this part was really around our engagement with our clinicians and consumers to come up with something that met their needs. And then the next bit is rolling it out into clinical spaces and seeing, where we can take it and where we go from there. So have a little look later on when it gets sent out, and I hope you enjoy it. And it's all courtesy of Jessica Cheers, our designer, who did an incredible job. And I think Joan was talking about the turnaround times. That was all Jess. I think she had a few sleepless nights.
Thanks, Natalie. And hopefully we can answer some questions now, Kate.
Yes, there have been quite a few, but I think some of them about feedback have been answered already. The one that I think would interest a lot of people is, how did you get funded for this? If other people want to take on this process, obviously there's, they need some funding.
So we're approached basically. So Queensland Health, we do a lot of projects for them, but also for Palliative Care Queensland and other health organisations. They come to us and they fund us to undertake projects. What I have been doing though is I've been training staff within health organisations, and I don't do consumer training, but I do train health organisations staff on how to run this process so they can run it themselves, and then we can support them to get their projects up and going. So yes, we're funded to do it, and in that funding that we get, of course, is a lot of that funding is actually to make sure that we remunerate and reimburse our consumers for their time.
Yep, essential. Okay. I'm not sure that that helps the rest of us get some funding, but thank you anyway. I think the one of this, and I don't want to dwell on this in a negative sense, but we've had a lot of discussion about the positives. What would you say were the negatives?
Around the kitchen table discussion?
The process.
I haven't actually come up with a lot. It's been a really interesting one because I think, you know, when I took them online, for example, I wasn't sure how that was going to work, and I had to move really, really fast with the onset of COVID. And I thought, oh, I'm going to lose this work and not be able to do it during this time. But we took it on and it worked. But what people said to me was the moment that lockdown was over or whatever, they wanted to go back out into community. They wanted to meet in a circle. They wanted to meet in together and be together. So for some, it works online and it's really great and it enables. For others, no, they say come back. Particularly for our First Nations people and those from other cultures, you know, that's so important to be in that circle, to have the food, etc. I haven't actually found, I guess because I've learned a lot over the last 2 years, you know, it is about making sure that when we're recruiting, we are recruiting, you know, people who have a real interest in this area. But there's not a lot of negatives that I've come across because, as I say, we enable and support the process for anyone to be able to host a session.
Which sort of leads on to a couple of intertwined questions, for want of a better term. You just mentioned there that you're not a trainer, but clearly the hosts are given training. Who's designed that?
Oh, I have.
Okay.
I have done training before, but because I've developed a process and I've learned so much with 200, you know, plus kitchen tables and 31 projects. So basically, yes, I have developed a guide to this for hosts and also for people who may be running projects. And so I know what to take people through, and, you know, and as I say, they also get a really great guide that we give them that helps them through that process.
Excellent. And I guess related to that, you mentioned mentoring, and Eileen has asked, is it peer mentoring? What's included for the mentors? So
with the mentoring, it's more that during that process, when the hosts, once they've had their briefing session and got all of their documentation, etc., and they've had their training, for that 2-week period of time where they're actually running their session, I make myself available, whether it's weekends, nighttime, daytime, whatever time, I make myself available. And Kira, who works with me, we're always around to support. So I've had very rarely does anyone contact me, but I have had people contact me on the weekend and go, and we're sitting in our session right now and we've got this question and I'm not sure I'm going in the right direction with it. Can you help me? I'm there to support that process. I'm there to support, you know, if there's any issues or if they're struggling to find people in community, because sometimes we can reframe it for them to help them find participants. And I know I've had some hosts that have said, look, you know, I'm really struggling to find people, and that can be an issue, if, you know, but I'll say, well, maybe if you go from this approach, and then they'll go out and say, oh, not only did I get enough participants, but I got too many. You know, so it's more from that perspective, but we are there to support the whole time.
Yep. Okay. Look, we're just about done for time. So there were a couple of other questions that I've copied the whole question text, so I'll get that over to you. Hopefully you've all come away feeling infused. I know that we've tried this technique as well, and the rich resource, the words that I jotted down were, feeling heard. It's about stories. It's about being with consumers, not to consumers. Rich tapestry, the enabling process, the yarning circle. So many really strong words came out of this presentation, and I simply can't thank you enough for sharing your stories and your professionalism with us. So thank you very much, ladies, and thank you to the participants. We will send out the information to you. I've promised everybody, without actually asking you, that we can share the slides, but I'm assuming you're okay with that since it'll be on the video anyway. But a lot of people would just like access to the slides. But yes, thank you once again, and good luck with your future ones. All right.
Thanks, Kate.
Thank you
everyone for joining in.
1 minute to spare. Grab a coffee. All right. Thanks, ladies.
Bye.
Bye.